I am Dr. Farah Siddiqui from the SRL Technical Center of Excellence. And today it is my privilege to introduce to you our team from SRL Mumbai, the team from the SRL Histopathology Center of Excellence. This is led by Dr. Kunal Sharma. Dr. Kunal is Associate Director of the center. He also leads digital pathology and AI initiatives for SRL. Kunal is a very active histopathologist within our SRL team. He has been with us for close to 4 years now. Previously, he was spearheading the histopathology department in the SRL lab at Fortis, Bangalore. Over there, he was also in charge of the reference center of uropathology and made a good name for himself. And we also were successful in establishing a close connect with the clinicians over there. He has numerous publications to his credit. He has worked actively on double hit, triple hit lymphomas from India and has one of the largest series over there. This he has presented at the International Leukemia, Lymphoma and Myeloma Congress in New York, pre-COVID, of course. And he has been active in publishing. He has numerous papers to his credit in national and international journals. And he is also a very popular speaker. He has been a keynote speaker, faculty at various national and international conferences. I could just go on and on, but I think we should progress with what we are here for today. So this center that we have, the SRL Center of Excellence in Histopathology in our reference lab at Mumbai, gets a lot of cases for second opinions. And today this team is going to take us through how they address these cases, the interesting cases that they have seen. And the topic is entitled Googlies in Second Opinion Cases, How to Crack the Toughest of Nuts. So Kunal, as we start, would you like to introduce your team?
Yeah, am I audible, ma'am?
Absolutely.
So along with me, I have two co-speakers. One is Dr. Vishakha and one is Dr. Veena. Dr. Vishakha she has done her MD from Bombay Hospital, and she's been associated with SRL for last 7.5 years. She has a special interest in soft tissue, CNS and pediatric malignancies. And she has also been spearheading the renal transplant and medical diseases biopsies in the Mumbai lab. We also have Dr. Veena with us, who has been associated with SRL since 2015. Dr. Veena is a fellowship holder in GI and liver pathology from AIG, Hyderabad. And she has a keen interest in gynec malignancies and medical diseases of liver, along with oncopathology. So the order that we will be following, ma'am, would be Dr. Vishakha would be speaking first, followed by Dr. Veena, and I will be closing the session. So I would switch over now to Dr. Vishakha for the presentation. I'll just share my screen. Is the screen visible?
Yes, it is, but you would need to make it full screen.
Yeah. Okay. Over to Dr. Vishakha.
So very good afternoon, Dr. Abha ma'am, Mr. Farasat, and Mr. Jay Malhotra has also joined in, I think. And so we shall quickly begin with this presentation. Okay. So case number 1, this was a 58-year-old female who presented with vaginal bleeding since 1 month and abdominal pain. On per speculum examination, there was a uterine mass which measured some 20 by 10 by 6.5 centimeters. The cut surface was cystic solid. Endometrial cavity was not identified separately, and bilateral parameter as well as uterine serosa were grossly unremarkable. So we go for the H&E images. As we can see, this is a spindle cell mesenchymal tumor. So we can very well see that there is a peculiar arrangement, pseudo-papillary configuration of the spindle cells is there, and the cells look quite uniform in morphology. They're spindled. See this, we can see here, there are the vessels, and the spindle cells are showing little palisading around the blood vessels. So the mitotic activity we can see in this left side image, we can see the mitotic activity is very well evident. So it was about 8 to 10 mitotic. The mitotic rate was 8 to 10 mitosis per 10 hyper field, and there was abundant tumor cell necrosis as well in the right sided image. So now we go to the IHC. So on morphology, basically, my first differential was a high grade endometrial stromal sarcoma, or it could have been some undifferentiated uterine sarcoma or angiosarcoma because it was very vascular. And of course, I would have ruled out a leiomyosarcoma as well. Now we go to the IHC images. This was Vimentin, which was beautifully diffuse and strong positive. CD10 was focal positive. I considered it non-specific. ER was diffuse strong positive, nuclear positive. WT1 also showed positive in few of the cells. These were number of negative markers, like I had ruled out angiosarcoma, CD34, 31 was negative. Hemangioendothelioma, the aggressive variant, CAMTA1 was negative. Then one of the differentials, I thought of uterine tumor with sex cord-like differentiation, but it's a low-grade tumor. Still, I did scalretin CD56, which were negative. SMA was negative, so not a leiomyosarcoma as well. So the final diagnosis was high-grade sarcoma, which favoring undifferentiated uterine sarcoma with pseudopapillary architecture. Now, the clinical significance of this diagnosis nowadays is that there are a number of molecular aberrations which have been diagnosed in undifferentiated uterine sarcomas. This is very important, because it may benefit the patients with targeted therapies. Now, coming to undifferentiated uterine sarcomas, there are microscopically, we can categorize them into two subtypes. The ones with uniform spindle morphology usually show NTRK fusions or PDGF Col1A1, PDGFB mutation like DFSP, and those with epithelioid morphology may show translocation 1017 with YWHE FAM22 translocation and BCOR translocation. BCOR translocation is seen with ZC3H7B, and also there are internal tandem duplications of BCOR. So if such molecular aberrations are diagnosed, we can definitely initiate the targeted therapy for such patients. That's why molecular diagnosis is very important for such tumors. So with this, I finished the first case. Moving on to the second case. This is another one, a very interesting soft tissue tumor. This was a 22 years old male who presented with a lump in the back region, which measured about 8.6 to 8 centimeters. And on radiology, the soft tissue mass was absolutely confined to skin and the subcutaneous tissue. So these are the H&E images. You can very well see it's a subepidermal tumor. The epidermis is very intact, not ulcerated. We can see that the tumor was mitotically active. There were about 10 to 12 mitoses per 10 high power field. The cells were spindled, and we could see some osteoclast-like giant cells also. We can very well note them at the periphery. And also there were some compressed giant cells amidst the tumor cells. There was no necrosis as such, and the tumor was not infiltrating the subcutaneous tissue, subcutaneous fat. So the positive markers here were Vimentin was diffuse strong, CD4 was diffuse strong, CD163 was diffuse strong, CD4 and 163 determine a histocytic lineage. ERG was focal, CD31 was also diffuse weak, and Ki was very high, around 50 to 60%. But still, this is not a malignant tumor. It's absolutely benign tumor, and the diagnosis was mitotically active juvenile xanthogranuloma, non-lipidized subtype. Now, juvenile xanthogranuloma, as we know, it's a benign histocytic inflammatory disorder. And there are two subtypes, morphologic subtypes. One is the classic form, which we know, where we get sheets of foamy histiocytes and numerous multinucleated giant cells. with very minimal mitotic figures. And the other is the non-lipidized variant where we do not find any foamy macrophages, but the mitotic index is very high, sometimes going up to 23/10 high power field. So that's why the clinical significance of this case lies in this, that we need to identify both the variants. Now, with this, I finished the case 2. Now moving to case number 3. Oh, so he was a 60 years old male patient presenting with an axillary mass that measured 3.9 by 2.5 centimeters since 4 months, and a biopsy was attempted. This was a true cut biopsy. Now, actually the morphology is very typical, but the differential diagnosis which came to my mind was that of a sclerosing fibroepithelioid sarcoma was the first differential, and this my second differential was could be some non-Hodgkin's lymphoma, known case, maybe post-treatment, maybe that's why a lot of sclerosis would have been there, but I was not having any other history apart from this. So the positive markers which came were MUC4, which is very, very specific for fibromyxoid sarcoma. That is the fibromyxoid sarcoma, sclerosing fibroepithelioid sarcoma is a variant of LGFMS. So we can see your Vimentin is diffuse, strong positive, and MUC4 is also nicely positive in the cells. So we did perform number of markers. This was only on the request of the clinician. I did because I didn't find any additional marker was required in this case, because Vimentin MUC4 were positive in the first panel itself. So still I have ruled out non-Hodgkin's lymphoma, leiomyosarcoma, plasma cell myeloma, and what else? So this was a classic case of sclerosing epithelioid fibrosarcoma. Now the clinical importance of this case lies in that it's morphologically and molecularly related to low-grade fibromyxoid sarcoma with MUC4 expression. And at molecular level, EWSR1 CREP3L1 gene fusion is seen in about 80% cases, with few cases showing translocation 716, that is first CREP3L2. So basically, these are more aggressive than LGFMS with a shorter survival, high metastatic rate, greater propensity to involve the soft tissues and bone, and proximal location as well as a larger tumor size indicate a very poor prognosis. Recurrences and metastasis to lungs and bone are common in about 50% cases. So with this, I finish case number 3. Let's move to case number 4. So
Vishaka, how many cases do you have?
Ma'am, this is the last case, ma'am.
This is the last case. Okay.
Yeah. So this is the last case with single diagnosis, but 2 different clinical settings. So in the first setting, this was a 77 years old male who presented with a pancreatic mass and a right parotid gland enlargement. So we received our Whipples. On Whipples, we found a pancreatic tumor, which was very well reported as moderately differentiated adeno-CA. And parotid gland also showed a gray-white lesion. But on diagnosis, I will show you. So these are the H&E images of the pancreatic mass, where we can see it's a moderately differentiated adeno-CA. And these are the images from the parotid mass. Now we can see it doesn't match with the morphology of the pancreatic mass. Although there are glands which are lined by cuboidal cells with very preserved NC ratio, very benign looking nuclei, a little like oncocytic tumor, if you can say. So CK7 and 19 were positive in this parotid mass, but CA 19.9 was negative. Even CDX2, P53 were negative. So we did P63. P63 was lining those glands in the myoepithelial cells. So basically, this was a non-neoplastic lesion by the name multifocal adenomatous oncocytic hyperplasia of parotid gland. So the similar case was one with 44 years old female who presented with an isolated parotid gland enlargement. Here we can see the morphology is absolutely the same. The patient was absolutely healthy, no complaints, and IHC markers were the same. Pan-CK, CK7 was positive, and spindle cells around the acinar cell nest expressed P63. So number of negative markers to rule out any malignancy. KI was just 4 to 5%. So this was the final diagnosis. And with this, I end my presentation. Now I would like to invite Dr. Veena to present her cases.
If there are any questions regarding these cases, we can take those. Any questions, any comments? If anyone wants to be unmuted, we can do that too. Okay, so let's carry on. Dr. Veena. Dr. Veena, please continue and we'll take questions at the end then.
Yes, ma'am. A very good afternoon and warm regards from Mumbai. Although it's not very warm here, it's raining very madly today in Mumbai. So very quickly, I'll be discussing 3 cases. So case number 1 is a 68 years old female patient. This case was referred to us from Ethiopia, from the Giran hospitals. It was a 1 paraffin block of a splenic biopsy. So this was a tissue, and on radiology, the diagnosis was given as multiple splenic lesions, query hemangiomas, and on CT scan, it was splenic nodules. Of query, some hematological malignancies. So primary diagnosis given at the by initial workup was an undifferentiated neoplasm with a differential of a lymphoid neoplasm associated with extramedullary hematopoiesis to rule out lymphoproliferative neoplasm in progression or hairy cell leukemia. So with that morphology, with that clinical details, I will like to share the microscopy. So this was a linear core from the splenic lesion. As we can see, it's a very cellular lesion with which is fully packed, and there is this proliferation of cells with atypical lymphoid-looking cells, and also there are areas which are showing extramedullary hematopoiesis in the form of erythroid precursors as well as the megakaryocytic precursors. But the interesting thing is those atypical cells which are looking little plasmacytoid, which were looking little plasmacytoid to us with perinuclear HOF as well as eccentric nuclei. So this was the initial diagnosis which was given. So on that basis, we ran some ILC markers. So CD3 was negative, CD20 was negative, CD79A was also negative, CD5 negative, TRAP was negative, CD10 was negative, CD23 was also negative. BRAF also to rule out hairy cell leukemia are also negative. CD117, CD123 was negative. BCL2 had come strong diffuse positive, NXtin1 was negative. Ki67 of this lesion was around 50%, and there was also diffuse MUM1 positivity. So till now, it was BCL2 positive with MUM1 positivity. So we carried out 138, and this was the marker which won the race, and it is along with kappa and lambda. So kappa showed the light chain restriction. So on morphology, it is looking what we felt like plasmacytoid cells were actually atypical plasma cells, and which were CD138 positive along with kappa light chain restriction. So also there was BCL2 positivity along with MUM1 positivity. So why should BCL2 come in a plasma cell lesion? And so we saw some articles like a high BCL2 expression are predictive biomarkers for response to combined chemotherapy regimens in multiple myelomas. So there is one more article which says BCL2 family inhibitor in the biology and treatment of multiple myeloma. So this is a cell promoter survival and frequency upregulated in multiple myeloma, making them very attractive targets. So BCL2 also comes positive in subset of cases with multiple myeloma. So it was a monoclonal infiltration by pleomorphic plasma cells expressing kappa light chain, and the final diagnosis was given as plasma cell dysplasias, multiple myeloma with extramedullary hematopoiesis. So the presence of extramedullary disease, this patient didn't have any bone marrow involvement. So the lesions were only in the spleen. So the extramedullary disease correlates with a more aggressive presentation and higher risk of disease, and usually has very elevated LDH levels. More frequent the presence, this presence is a poor prognostic factor, and there are deletion of 17p and clonal mutations. In this extramedullary disease, the histological findings show clonal plasma cells which are more frequently immature and plasmablastic in appearance. So this is my with this I end case number 1. Case number 2 was a 50-year-old male patient who was referred from Kenya, and it was an institutional biopsy from left arm. And this was the initial radiological workup. It was a well-defined heterogeneously enhancing mass around 12 centimeters in the medial aspect of the left arm, and there were significant areas of necrosis. So the initial diagnosis which the pathologist gave there was a high-grade myxoid sarcoma with differential of myxoid fibrosarcoma, dedifferentiated myxoid liposarcoma, extraskeletal myxoid chondrosarcoma, and myxoid MPNST. Basically, there was a lot of myxoid matrix along with high-grade areas. So this is a morphology, and this is a biphasic looking tumor with a lot of hypocellular and hypercellular areas. On high power, there is looking like little bit of papilloid architecture with lot of blood vessels, and this is typical cells with which are surrounding blood vessels, and there is little bit of enlarged nucleus with atypical with increased mitotic activity, and this myxoid secretions are also there. So on IHC, vimentin was strong and diffuse positive. Pancytokeratin was negative, so it is not an epithelial malignancy. SMA and S100 was negative. CD34 was negative. What was positive was desmin, which was strong and diffuse. So MyoD1 was also strong and positively positive, along with a KI of around 70%. The negative markers included SOX10, STAT6, SANAP2, HME45, and CD45. So this is a case of a high-grade sarcoma with skeletal muscle differentiation like pleomorphic rhabdomyosarcoma. So because of the morphological presentation, it was misdiagnosed as a myxoid high-grade sarcoma, but it was a pleomorphic rhabdomyosarcoma. Coming to the case number 3, it's a 51 years old male patient was referred to us from Andhra Pradesh, Kurnool, with multiple ulcerative lesions, and the primary diagnosis skin lesions, and the primary diagnosis was given as poorly differentiated malignancy suggestive of lymphoma. So this is the biopsy. On scanner view, it is showing skin, along with that a dermal infiltrate of atypical cells, and on higher magnification, the dermal infiltrate of atypical lymphoid cells is showing little bit of epidermotropism, and there are these typical cells with high atypical cell morphology. The mitotic activity is really high with these atypical cells which are showing hallmark kind of morphology. On IHC, CD3 showed some wishy-washy kind of positivity along with CD20, which was negative. CD30 was strong and diffuse positive. PAX5 was negative. CD56, EBV, LMP were both negative. Pan T cell markers, CD2 was positive, CD4 was strong and diffuse positive. There was partial loss of CD7 and CD5 was completely lost. ALK1 was negative, CD138 was also negative. So also BCL2 was also positive, CD10 also was positive with a very high KI, which was nearing about 80 to 90%. So on multiple occasions, we tried to get some clinical data, but this clinical image we got only after we made the diagnosis. So this is definitely a malignancy with generalized lesions of varying umbilicated lesions with ulcerations and central necrotic sloughs. So this is a classic histology of primary cutaneous anaplastic large cell lymphoma, consisting of circumscribed nodular lesions which are infiltrating the dermis, composed of large atypical lymphoid cells and with subtle epidermotropism. So we should differentiate this from primary cutaneous ALCL from the benign entity which is called as lymphoid papillomatosis, and which has overlapping features. So lymphoid papillomatosis is a chronic skin condition and has histology of a lymphoma. It is typically a recurrently self-healing lesion and has excellent prognosis. So what is the difference is the molecular alteration of by DUS-P22 IRF4 locus is less frequently seen in lymphoid papillomatosis than primary cutaneous ALCLs. So anaplastic large cell lymphomas are divided into primary cutaneous ALCL, systemic ALCL, and the breast implant associated anaplastic large cell lymphomas. So molecular alterations in the primary cutaneous anaplastic large cell lymphomas include in the descending order frequencies, DUS-P22 rearrangements, ALK translocations, PP63 rearrangements, and NPM1 TYK2 gene fusions. So our final diagnosis, we gave it as a CD30 positive, ALK1 negative cutaneous anaplastic large cell lymphoma. With that, I end my discussion on the cases. Are there any cases we can take it now or maybe at the end?
Maybe we'll take them at the end. There's nothing on the chat as yet. So I'll invite Dr. Kunal Sharma now
Yes.
to show us his cases.
One second. Okay, so I think we've had a potpourri of really, difficult cases till now. The juvenile xanthogranuloma with increased mitotic activity was definitely one of the most, tricky diagnosis to make, because the difference was between benign and malignant. So I would like everybody to just keep shooting their questions in the chat box, and let's go on another journey of some difficult nuts that we had to crack. So what I have tried to do is cover, most of the systems. Like, you will have a carcinoma, you will have a lymphoma, and you will have a mesenchymal neoplasm. So with that, let's go to our first case. This was a 70 years old male patient for whom we got a skin biopsy for review. Radiologically, the patient did not have any organ involvement. It was primarily a cutaneous disease. And grossly, what the patient had was a fleshy, ulcerated, and violaceous nodule. This was reported outside as a malignant small round cell tumor with differentials of amelanotic melanoma and a lymphoma. So when I saw the morphology, the epidermis was ulcerated, and below we could see these really blue cells, which were mostly round to oval, and they were present in sheets. When we go on the higher power, what we see is that these had sort of a stippled salt and pepper chromatin, and there were mitotic figures, including atypical forms that were seen. They had very scant cytoplasm, and they all look very basaloid. So, after that, I knew that we were primarily dealing with a small round cell neoplasm, and which had a sort of neuroendocrine kind of chromatin details. With that, we threw in our IHCs. So the first thing that I like to do usually is lineage specific markers. In that, we saw that this case was positive for CK. It was negative for HMB45 and CD45. Those were imperative because somebody else had given a differential of lymphoma and melanoma. On further testing, we got positivity for synaptophysin, CK20, chromogranin, and CD56. So these are neuroendocrine markers, as we all know. And just to put it in a nutshell, the case was positive for CK, CK20, synapto, chromo, CD56. KI was about 40%, and it was negative for CD45, so no lymphoma. S100 HMB45, so we know no melanoma. So what are we dealing with then? So this is a relatively easier case. Did not take much time. The level of detection wasn't that tricky. Little boys can do the trick. So this was a Merkel cell carcinoma. It's important to know that this is caused because of polyoma virus and because of UV exposure. And it's also imperative to know that we have to differentiate this from a metastatic neuroendocrine tumor, which could be elsewhere in another organ. So it's very important to understand that, this should be ideally a primary cutaneous disease, and there should not be any other organ involved to rule out metastasis completely. We also have an IHC for polyoma virus. We don't have it currently in Mumbai, but we are looking forward to acquire it as soon as possible. Coming to my second case, this was a 65 years old female from Ethiopia. Biopsy was taken from a proximal fibular lesion, which was predominantly soft tissue based. And the primary diagnosis given was a high grade sarcoma. Differentials that the primary pathologist gave were of sclerosing epithelioid fibrosarcoma and extraskeletal osteosarcoma. So these were interesting differentials, and I wouldn't completely deny these differentials when you have a primarily soft tissue disease, which looks to be surrounding a long bone. So when we saw the morphology, what we basically saw were a little epithelioid to short spindle kind of cells. And there was this sclerosing pattern to the whole picture. When we go on high power, we'll see that, these were a little epithelioid to short spindle cells. These weren't entirely, very classic spindle cell neoplasm. So that is where, I wasn't very convinced towards a fibrosarcoma or even an osteosarcoma. But this sclerosis can very easily be confused with malignant osteoid. What we also saw were really atypical mitotic figures, and the nuclei were somewhat vesicular. So with that, I knew one thing, that this is most likely a mesenchymal neoplasm, but it's imperative that because of the little roundish pattern, we still throw in a CK and a CD45 in these cases. So again, my primarily panel was of CK, CD45, S100, and Vimentin. Vimentin came positive. KI was high grade. This was about 50 to 60% KI. BCL2 came positive. CD34 came negative, and TLE1 came negative. I threw in a TLE1 because BCL2 and TLE1 co-positivity, kind of guides us towards a synovial sarcoma. But we must know that in synovial sarcoma, the TLE1 that comes should be very strong and diffuse. So here, I mean, nothing was really positive. S100, SOX10, everything was negative. And CD34 was also negative. So something struck me and I threw in some more markers. And one of the markers which I threw in was STAT6. And as you can see that it came beautifully diffusely nuclear positive, but CD34 was negative. So in a nutshell, the case was positive for Vimentin, BCL2, and STAT6. It was negative for all the other markers of relevance, and KI was about 60%. So this case was a little more tricky than the previous one. We needed a detective of a little higher repute to solve the mystery. And this was actually a case of malignant solitary fibrous tumor. What I want to drive home through this case is that malignant SFTs can be negative for CD34. And just because 34 is negative, that should not, kind of deviate us away from the diagnosis of SFT. And we must always throw in a STAT6. Another important thing to note is STAT6 is a wonderful IHC marker. This is one of the rare instances that an IHC marker is considered more reliable than a FISH fusion in cases of SFT. Another being ALK, as we know, in cases of lung tumors. So with that, I would like to go on to my next case. This was a 72-year-old male patient who presented with multiple left level 2 lymph node enlargement. The largest node was about 3 into 3 centimeter in size. The patient had B symptoms, and he had a very typical history of pruritus. First, he was diagnosed by a primary pathologist as lymphoproliferative disorder, which was then taken to another center of, a referral category, and there he was diagnosed as THR-BCL. There, the treatment was started for THR-BCL. The patient did not respond. Disease kept on progressing, and then the clinician called me, and we got the case for a second opinion. So when you see the picture, we can easily make out that the lymph node architecture was completely effaced. What we see is that there is a diffuse infiltration of a variety of cells. These look from small to intermediate size to large size, and they have like sort of a clear cytoplasm. So whenever you have a picture like this, one thing is that you are more, you should never rule out either of the two. I mean, no Hodgkin's and no non-Hodgkin's, because a polymorphous infiltrate could be anything. So that makes, this case a very ripe case for IHC evaluation. What we also saw were a little large looking cells, as you can see in this picture, where they look more of like immunoblast kinds and, histiocytes. So definitely this had larger cells, mostly mononucleate, which were immunoblast-like in picture. This had a polymorphous background, which consisted of plasma cells, polymorphonuclear leukocytes, and histiocytes. And this had another diffuse population of small, intermediate, large cells with nuclear molding, and some were showing prominent tiny nucleoli. So this is again to show you the same thing. And what you can also see is that there were a lot of atypical mitotic figures. So with this, I was very clear that this doesn't look like a classical Hodgkin's. I did not see any classical RSLs either. And a picture like this very often, tilts me towards the diagnosis of a T-cell lymphoma. So we threw in our stains and we saw that CD20 was scattered here and there. Probably this is what misled somebody to make a diagnosis of T histiocyte-rich large B-cell lymphoma. PAX5 also showed similar staining as CD20. There was no categorically, differential staining that was noted on PAX5. CD3, as we can see, was pretty diffuse. CD2 almost stained as CD3. And as Dr. Veena said that we do a pan T-cell markers for T-cell lymphoma, we see the loss. So the markers we typically do are 2, 3, 5, and 7. And then we see whether it is a T helper phenotype with 4 or whether it is a cytotoxic phenotype with 8, 56, perforin, granzyme, TIA1, those kind of markers. So here, if you see, CD2 is considered a pretty stable pan T-cell marker. So we see that there is 3 and 2 are pretty much diffuse. 7 looks pretty conspicuously downregulated, and CD5 was also relatively downregulated. So this tells you that this is a T-cell neoplasm. On putting further markers, this was positive for CD30, TIA1, CD4, and CD8. So what it showed was that there was an upregulation of cytotoxic phenotype. The Ki67 was very high, about 80%, and I was very tempted to throw in Eber-Risch, which came diffuse positive. So what we have in a nutshell is positive for CD3 to granzyme TIA1, CD30, CD4, CD8, and Iberrish. There was downregulation of CD5 and CD7, and the case was negative for CD20, PAX5, ALK, EMA, 10, BCL6, TTT, and GATA3. We do 10 and BCL6 to rule out an AITL, which could be a very tricky differential in some of these cases. Because the Ki67 was high, I was tempted to throw in a TDT. And I'll tell you why I did GATA3 at the end of my diagnosis. So why do we have only, foreign detectives? We should also celebrate some of our Indian ones. A very famous, detective series. So this case was a very interesting case, as this was a case of Epstein-Barr virus positive nodal peripheral T-cell lymphoma. A very important thing that I would like to share is whenever we are dealing with a PTCL, we can very often see EBV positivity, but that is usually seen in the large cells, which are the B lineage cells. This is a case only in up to 5% of the cases that we can actually see this EBV positivity diffusely. It is important to understand these cases because these show poor prognosis. And these are very often the cases that would need transplants. Another important thing which I wanted to tell you is that these days, it's not enough just to diagnose PTCL. We must give a molecular subtype to PTCL. So there is the TBX category, and there is the GATA3 positive category. The GATA3 positive category shows much poorer prognosis. It is in that we see at least 50% of cells to be positive for GATA3. So that's why I had thrown in a GATA3 in this case of mine. So this was a case of PTCL NOS, EBV positive. Now coming to the last case, which somehow happens to be one of my favorite cases in a long time. This was a 74-year-old male patient who presented with increased counts and lymphocytosis. The peripheral smear was suspicious for a CLPD, and the bone marrow aspiration examination showed a metastatic adenocarcinoma to the primary pathologist. And bone marrow biopsy also showed a metastatic adenocarcinoma. So the clinician was completely confused. He said, if you have a metastatic infiltration, you should actually have decreased counts. Here, the peripheral counts are increased. Peripheral picture is like a CLPD. Peripheral smear shows a picture like a CLPD. And bone marrow examination shows us adenocarcinoma. So we got the bone marrow biopsy for evaluation. And this is how it looked. So I want all of you to have a very clear view of how this bone marrow looks. There are some, on the right side, we'll see that there are these lymphoid aggregates. And on the left side, you can easily see that there is an infiltration by atypical cells. In the right picture, what we will see is that these atypical cells seem to have, these are probably arranged in clusters, and also they probably glandular, probably pseudoglandular. They don't look very, typical of either squamous or adenoid morphology, but very easily these can be mistaken for a metastatic adenocarcinoma. So with this, I threw in my stains, and what I thought is what it came out to be. I actually thought that this was a pseudoglandular arrangement in a squamous cell carcinoma. So I threw in the squamous stains, and they were beautifully positive. P63, P40, and CK5/6 came positive. We all know who this is. So I was like, okay, we've solved the mystery. But something was still not, I was still not happy. We did have CK7, CK20, all the other adenocarcinoma stains also thrown in, which all turned out to be negative. So I was pretty clear that this looks like a metastatic squamous cell carcinoma, but something is not right. And those lymphoid clusters were somehow troubling me. So I thought, let me just evaluate them. And what we did is that I looked at them carefully, and I threw in the lymphoid markers. So the clusters were beautifully positive for CD20, as you can see in this slide. They were also co-positive for CD5 and CD23, and Ki67 was very low in these clusters, about 5 to 10%. So you have a patient with atypical epithelial cells positive for CK5/6, P40, P63, negative for the other relevant markers, and a lymphoid cell population positive for 25, 23, BCL2, and LEF1, which was negative for the other relevant differential markers. We ruled out because it looked like a low-grade picture, so it's imperative to rule out a follicular, marginal, and mantle in this case. So finally, we come home. This was a case of metastatic squamous cell carcinoma along with a CLL bar SLL, and later, on PET was done later, and the patient was shown to have a 3 into 2 centimeter sized FDG avid uptake in right lung with multiple pleural nodules. So that is where the squamous was coming from. And flow cytometry was done on the peripheral blood because they could not take the aspirate again. The primary aspirate, they said, was a metastatic adeno, so they didn't go for flow in that case. So that flow in the peripheral blood showed positivity for CLL. With that, I would like to conclude the session. And these are just some of our different conferences that we go to. And this is my team at SRL Mumbai.
Thank you, Kunal. Excellent cases, mind-boggling in fact, and compliments on your crisp IHC. Images were very good.
Thank you so much, ma'am.
There are bound to be many questions, many doubts. Please come up with them. Do not hesitate.
Okay, so
yeah, there is. Dr. Manoj wants to know the diagnosis of case 1.
Case 1 of which doctor?
The first presentation, Dr. Vishal.
Okay. Dr. Vishal, would you like to take it? Come.
So it was undifferentiated uterine sarcoma with pseudopapillary architecture.
That is the diagnosis. Right?
Yeah, that is the diagnosis.
Right. There are 2 questions from Dr. Nabanita. How is the vascular pattern in malignant SFT?
So,
would you like to unmute her?
I have.
Farasat, would you unmute her, please, Dr. Nabanita?
Done, ma'am.
Unmute to nahi hua?
Dr. Nabanita, you need to click on the notification.
Yes. Would you want to repeat your question, please?
So I just wanted to know the vascular pattern, like in benign solitary fibrous tumor, those staghorn vessels are there. So how about in malignant variant of solitary fibrous tumor SFT?
So Dr. Nabanita, you can find the similar pattern here as well. You can have dilated, staghorn appearing vessels, but what would be imperative would be the cytology of the cells around those vessels. In a malignant SFT, you will have atypical mitotic figures. You can have this, eosinophilic sclerosis kind of a pattern, and it will be clinically a malignant disease. So it's very important to keep in touch with the clinicians. But as far as your question goes about the vascular pattern, you can see the same vascular pattern even in malignant.
Okay. Was that a Trocar biopsy? Actually, I forgot. I saw so many cases. Now, what was that? Trocar biopsy or the whole tissue was there? In your case, means was that a Trocar biopsy? Your case, I forgot actually.
No. It was an excision biopsy.
A whole biopsy. Okay. And I have thrown one more question.
Yes, please go ahead.
I forgot only what did I ask.
I'll jog your memory. It was about gelatinous transformation.
Yeah. In the bone marrow, means some of the core were looking very pink to me. Was there that last case, na STC with CLL SLL?
So that is just sclerosis that happens because of the infiltration of the atypical cells.
Okay.
Gelatinous transformation looks very different from this. So whenever you have,
because I could not see the bigger image, na. I am logging in through mobile, so just a query.
So you can see a lot of sclerotic picture in a marrow when it is involved with infiltration of any sort, whether it could be leukemic cells or actually carcinoma cells show more of sclerosis in a marrow.
Right. So keep the questions coming. Meanwhile, Dr. Sunita,
I like to comment. I like to comment upon the squamous cell carcinoma in CLL. So I have a story to tell here. A very VIP patient. He had a periampullary carcinoma. So we diagnosed it here at FMRI, but he went to MD Anderson for his surgery. When they opened the abdomen and they found that the there is that cancer. And then the whole abdomen was filled with lymph nodes. And they took the lymph node out. One of the lymph node had a small mets. And the rest of the lymph node had follicular lymphoma. So they said that, don't worry about this lymphoma. This is not going to kill you. It is the periampullary which will kill you. He didn't die of the periampullary. He lived about 4 or 5 years after that diagnosis. And he died of the DLBCL transformation of the follicular lymphoma, which went up into his brain and used to come up with different masses in the thigh and retroperitoneum. And Dr. Rana would get a small biopsy and send us every time. That periampullary cancer never troubled him after that initial surgery. It is the DLBCL of the follicular lymphoma which killed him. So the behavior of cancer is not defined by the morphology or the whether a carcinoma or lymphoma. It is the molecular whatever defect or it is harboring, which will make it aggressive. So let's not be fooled by the look. We need to look deeper at the molecules. So please, when you get a biopsy, don't waste in doing all kind of IHC. Always, your aim should be you do minimum IHCs to make a diagnosis and save the tissue for the molecular diagnosis, because that is what is going to help in treatment and target.
Very well highlighted, very well highlighted. In today's age, the molecular profile of the tumor is more and more important, and there is more and more to offer, and it is changing. It is changing on a monthly, on a yearly basis. So it is very imperative. These are all very precious biopsies, and yes, we do get carried away by our diagnosis and our histopathology and patterns, and sometimes we are pressurized to do more and more IHCs because there's certain medical oncologists who will ask you, what about this, what about that? But it's a precious biopsy, and in the end, we are the custodians. We are the custodians, and we are in the best position to explain how you need to save that valuable tissue. Very well highlighted, Dr. Sunita.
Thank you.
I don't see any more questions.
Somebody has asked a question: in sarcomas, what is the role of radiology? Are they guiding or misleading? So I would actually say that, as far as clinico-radiological correlation is concerned, there is no information which is misinformation. Every small bit of information will probably help you get to the bigger picture, and radiology can sometimes play a very, very important role in sarcomas. Their locations can be very important. For example, as we know that if you are dealing with a retroperitoneal mass, it is liposarcoma unless proven otherwise. So those are the kind of things which will always help you, understand what you're dealing with. Somebody has also asked, we diagnose here morphology diagnosis. Can we suggest our IHC marker to confirm our opinion in common code of IHC of Mumbai, or is it limited panel? So Dr. Pathan, we have a custom IHC Z009K panel, which is an unlimited panel. I mean, the onus is on us to give you a final diagnosis right up to the T, and whatever amount of markers we have to do, we shall do to make sure that happens.
Yeah, so as Dr. Kunal said, there are multiple options, multiple test codes, and our team is always there. You can always reach out to them and they will guide you on which is the best possible panel to go for in the case that you are dealing with, depending upon your location and depending upon the sample that is available.
One more question. Actually, I think some of them, the questions are coming to me, not to everyone in the forum. So someone has asked, Dr. Brijesh has asked, how to differentiate between primary cutaneous ALCL and skin mets from systemic ALCL. Dr. Veena, would you like to answer this question?
Genetically, morphologically, there is no difference, but genetically, cutaneous ALCLs are a little bit less aggressive than the systemic ALCLs. And there is this DUSP24 translocation is less commonly seen in cutaneous ALCLs than in the systemic ALCLs. But morphologically, on IHC basis, they are both similar.
Also, I would like to add to this, Dr. Brijesh, that you also have to rule out a systemic involvement. For up to, you have to follow up the patient for about a period of 6 months post-diagnosis, because there should not be any nodes in the patient. You know, a primary cutaneous ALCL will not show you nodes, whereas a systemic ALCL will show you nodes and B symptoms. So,
Okay, I'm getting another question. It's from a number. He's asking how to send samples. Basically how to refer, I guess.
okay. So, that I believe the codes are available, and maybe, ma'am, you are in a better position to tell how we go about it, because we have separate codes for COE and we have separate codes for the Goregaon cases. And
Yes. So if someone is asking for a second opinion, I assume this is a second opinion.
the COE side.
So you would recommend the COE test codes. For all of you who are from within the SRL system, you are familiar with it. If you're not from the SRL system, then just reach out to any SRL representative or any one of us, and then we would be able to share the test codes with you. I don't see any more questions on the chat.
There are more, so I'll just tell you.
Nice. That's what we want. We want more questions.
Yeah. So there is one question that is directed towards Dr. Vishakha. The parotid lesion is why not oncocytoma?
See, the basic difference is that oncocytoma is a benign neoplasm. It's an encapsulated neoplasm. You will see a nice capsule around the neoplasm. Whereas in this case, it was a multifocal lesion. There was no capsule. And you could see the entrapped striated and intercalated ducts, which are the native ducts of the parotid gland. They were seen in between the foci of those oncocytic glands. So this is how I differentiated oncocytoma from this adenomatous hyperplasia of parotid gland.
That was a very interesting case.
Yes.
Very interesting. So
There is another. Okay.
Yes.
So one more question by I think the username is RP. They have written interesting case. What was the protein electrophoresis? Immunofixation electrophoresis on IHC CD38 was negative. Any update on CD56, PAX5, CD19 status? I think, Dr. Veena, this is for your case.
So initially, this case was not worked up in terms of multiple myeloma. So we had asked, after diagnosis, we had asked them to work up for serum electrophoresis and free light chain assays, and CD56 was negative in the case. It was the first time it was diagnosed because they were thinking of a hairy cell leukemia or a lymphomatous involvement of the spleen. So after this diagnosis, we had requested for the workup. This biopsy was referred to us from an international from an international case. So it was referred, and then after a discussion, we are following up with the case, and it is yet to be known, like serum electrophoresis pattern.
Any more questions, Kunal, that you have?
I'll just see, ma'am. Dr. Kunal, one more question I shared. Please check. 1 second. I'm just seeing. Our lab is, so Dr. Pathan again wants to know, our lab is having basic in-house histopathology with frozen study. What precautions we should take to yield good result in IHC study at your level? So this is a very, very pertinent question, ma'am, and I feel that IHC there is such a variety of staining that we see from lab to lab. What we really have to understand is that we should validate the IHC markers very, very, very strictly as per the protocols. Another important thing to note is that, cost cutting is good in terms of reducing your number of IHC markers and not putting irrelevant markers. But there are certain basic levels of quality which should not be compromised. For example, quoted slides should definitely be taken. There are centers I know who tip the slide, and then, that can be very, very difficult, because what happens is that the staining is not uniform. And as we are going forward, many organizations, for certain markers which are of prognostic importance, they are relying more and more on automated stainers because of this reason. So I believe, knowing where to cut costs, validating the IHCs extremely well. And in cases of companion diagnostics, I am still a very strong believer of single platform, single antibody, and single biomarker. So if you are doing 22C3, you should do it on a DACO platform. If you're doing SP263 and 142, it should be done on a Ventana platform with the guidelines. And this harmonization is not something that we have really been able to reproduce with very good results as of now.
Right. That's at our end, but I think his question was also directed towards what could be done in a lab that is not doing IHC in terms of fixation and ideal fixation.
Right. I think, yeah, I think that makes more also quite a lot of sense. So there, a very important thing would be to know the formalin that you're using. It should be nutrient buffered formalin, 10% NBF, as we know, and that most of the times makes all the difference. Plus, in bone marrow biopsies, decalcification is something that you need to overlook and follow the guidelines. Ma'am, you wanted to say something?
Yes, if it is, suppose you get a small bit like CNS, if you get a really small bit, then you have no option but to have the full, put full for the frozen section. But in case you get a sizable amount of 1 centimeter size of a bit for frozen, and you ask the surgeon whether you're going to get any more tissue or this is all he's going to send. If that is all he's going to send, then you need to use minimum amount from the most horrible looking area for the frozen, just to tell the surgeon that yes, I've got the lesion, the rest all you fix for IHC and the further paraffin talk. That is very important because frozen is not for diagnosis.
Correct.
Right.
So,
Particularly so for CNS tumors, they just want to know that
lymph nodes and stuff like that, even for the tumors like breast biopsies, sometimes they send you cores for frozen, all that. If they are sending 4 or 5 cores, you just process one and tell that yes, you are in tumor, but rest all you keep for the formalin fixation and for processing.
Right. So there are no more questions now. So with that, I think we'll conclude today's session. A big thank you to Dr. Vishakha, Dr. Veena, and Dr. Kunal. We have had a very interesting session. It's been a visual treat, and you have shown us some very rare and interesting cases.
Thank you so much, ma'am.
I think there's a lot more that you have to show us, so we will have a follow-up session too.
Sure, ma'am. Yeah. Thank you so much for having us for this session.
Thank you. Thanks a lot. And we will conclude today's session now. Thank you.